Secretary and Dr. Redfield reiterated over and over again that syringe service programs are going to be key into our ability to turn the tide on this. And so, when we look at a place, as we look across Indiana, we have several priority areas where these programs are particularly vital, and here is one of them, and that's why we're here today. You have had a lot of success from the state's view in the operation of your program. Your program is one of the best operating as far as the return rate goes. Nationally, you look and you see a lot of return rates in the 70, 80, even maybe 90% figure range there, but here we're looking at a return rate of 95%, and that is huge. And we look at the amount of interaction that people have with the site here. And those engagements, as we build our ability to work with folks and connect them to the services they need to stay healthy. I know at this point in time, most of us have family members that have dealt with some type of substance use. And it takes interaction after interaction, sometimes multiple attempts for people to maintain sobriety. And so when we look at having hundreds of opportunities to work with people who are actively using, those syringe service programs are one of our only ways where we're going to have an opportunity to take somebody in the throes of addiction and have an ability to at least have some kind of conversation or a chance to get them into, or maybe out of, that pre-contemplative place of change where we can talk to them about what options there are, and then also about health in other ways, because there are other types of wellness that we can focus on while people are still using actively. Some interesting information about your local area here. Y'all are over 2 times the rate, or the average rate, of hepatitis C infection for the state of Indiana. And so that's why this is a particular area of focus for us. And one of the things that we're dealing with now, on the HIV side, we always say that hepatitis transmission is a canary in the coal mine for HIV infection. And so when we look at these things, there's a lot of information nationally that they compile when they identify high-risk areas. And really, when we talk about high risk, we're talking about having the potential to have something occur like we've had down in southern Indiana, where the right conditions could produce an outbreak. And so the high rate of hepatitis C infection is something that we look for early on to say this is an area that needs additional services and particular focus on this one particular method of transmission, because people who inject substances are participating in the highest risk activity for HIV transmission that's out there. But we're going to end the epidemic. I am convinced that we have a very unique set of service providers here in Indiana, and we have a particular cohesiveness among all of the people in the state who are engaged in these activities. And so whether you're talking about the people who are providing services in Fort Wayne all the way down to the folks in Evansville, they talk to each other consistently, they share best practices, and they can work together to improve programs and make them fit for what the community needs. And so I think as we look at how best to keep these things going, we have a variety of resources. Erica does a great job with the harm reduction program, and we at the state, we want to support what you all decide is best. And so we're here to make whatever we can work for you. We want to make sure that you have access to the best information out there. We want to take public health, and we want to look at public safety, and we want to meet in the middle there and find the best path. And we have resources. Captain Hunter from Fort Wayne is a narcotics detective that can help us and come into communities and identify where there might be some trouble spots, iron out any wrinkles that need to happen so that we can keep these programs alive, because we have over a couple hundred people here who are reliant on this, that we want to make sure that we don't lose and that we can connect them to help. Now, when we look at hepatitis, your HIV issue is not the main concern here at this point. Hepatitis, obviously, we see a lot more transmission of that happening, and we're at a place now where hepatitis is curable. And so when we look at HIV, we're talking about an issue that people will need to be connected with services for the rest of their lives and be able to afford the medication to keep their viral load suppressed. And so when we have people living with HIV and their viral load is undetectable, the CDC has come out and said if their viral load is undetectable, they can't transmit the virus to anybody else. And that's great. But with hepatitis, we're looking at a cure now. And so for every day, though, in Indiana, right now, about 22 people get hepatitis. And it costs at least $28,000 per person to treat that hepatitis. And so for every time somebody's getting infected, you know, we're taking up another 28 grand that we're going to have to pay for the treatment. And that's to the tune of $544,000 a day. And so the sooner that we can end this hepatitis epidemic, the better. Obviously for personal health, but also because when we think about all of the resources that we're directing at that, just think about what else we could direct resources to after we get to the other side of these epidemics. And so that's where we want to be, making sure that we have access for folks, stay healthy, stop the spread of disease as much as we can, and connect everybody who's infected with the services that they need, either to maintain wellness or to be cured. And so that's where we are at in the epidemic. We're going to be working with communities across the state. At this point in time, we've applied for a grant from the CDC to do our statewide plan. It's going to take about a year because we want to make sure that we are getting the voices of everybody, whether they're, you know, the people at 2 North Meridian or the governor's office, all the way, you know, down to where I'm from, the hills and hollers down south, and, you know, getting everyone's input, because this statewide plan is going to be comprehensive. And it's going to be something that's going to take us all working together to make happen. So SSPs are a big part of that. We appreciate all your work that you've done, and we want to know what you need from us to continue to be successful. So ISDH is here to be a good partner for you. So I don't know if that was a nice overview of everything, but I'd be happy to answer any questions that people might have, and to talk about a little bit more in detail. If you have questions about how other programs are operating, Erica is intensely familiar with how our other SSPs are operating, and you know, we'd be happy to answer any questions that you have.
I guess starting off, do you have Fayette County's numbers in front of you? Or
Yes.
can you kind of go over those numbers with us?
Absolutely.
So we can better understand what we're looking at?
Right now, we have 206 folks that are registered participants in the program. About 118 of those folks are male, and 88 are female, and then we have less than 5 who are transgender. Right now, up to this point, they have been provided 36,742 syringes, and they have returned over 95% of those, 34,807. You have had 827 opportunities to connect people with resources. Your top 3 referrals that happen from the program are for substance use treatment, for substance use recovery support group, and for educational resources. It looks like here the substance use and mental health services were provided as referrals 696 times through that program. So we have some quotes that I can share from some of the quarterly reports that we get at the state. It says, I recently had a young man come in who'd been kicked out of his house wearing 2 hoodies, pajama pants, a pair of gloves, and a cap. He'd been walking the streets all night because he had nowhere to go. The temperature was in the 30s that night. I am able to purchase coffee to offer my freezing people when they come in, not only him, but my participants who walk 30 blocks one way to exchange their needles. It's amazing how much a simple cup of coffee is appreciated and the impact that small kindness has on people. Another comment, I recently spoke with an addictions counselor at a treatment center. She stated that for years, almost 100% of people being tested on intake were positive for hepatitis until recently. She had 2 people tested that were non-reactive, and they were both participants of our program and received clean supplies. I was very encouraged by that. It looks like there have been no change in your HIV incidence for both years. And then in 2017, we had 105 people test positive for hepatitis C. And then in 2018, that went down to 79. The 2017 count for non-fatal ER visits due to any opioids were 90. And then that went down to 27 in 2018. The deaths from drug poisonings in 2017 was 20, and then that was down to 15 in 2018. And so I think that we do have some good numbers there, some anecdotal information just from reports, but also definitely some positive outcomes that we're seeing early on. Now, keeping in mind that a couple of years worth of data is not necessarily something we can point to a trend quite yet, but I think that things are moving in the right direction, and it's positive anytime we don't see an uptick. Now, one of the things that we talk about, we were just talking on this end of the table a little earlier, is that hepatitis is a lot more contagious virus than HIV is. And HIV is really poor at living outside the body. Once it's exposed to air, the transmission risk is really when you're dealing with things immediately. With hepatitis, it can live outside the body for a very long time, particularly inside of a syringe in that vacuum. And so hepatitis is over 100 times more contagious than HIV. And that's due to the fact that once a person's exposed, it's easier for them to be infected, because not every time somebody's exposed are they infected. So they could be exposed to someone who's HIV positive and not transmit infection that time. Same way with hepatitis, but it happens a lot more frequently. And then a syringe can sit there for days unused and still be able to transmit hepatitis, whereas it would not be able to transmit HIV. And so those are the primary things that we'd like to cover in the difference there. And so it's why we see so many people impacted by it. It's easy. You think about, too, one of the things that's so hard is we think about having a cure for something, and you think, wow, we can cure hepatitis, everybody's going to be cured. Well, it doesn't just happen overnight, And one of the other things, too, is just recently, as of July, Medicaid had all kinds of requirements to be able to get your hepatitis cured. And so you're dealing with people out there who have known some of them have known they've had hepatitis, but they went to the doctor and they said, hey, you're not sick enough to get cured. Well, we know that's a public health issue there, because when they're not cured, they're able to transmit to other people. But then they've lifted the restrictions on people being able to get treatment, but now we got to get the word back out to everybody, because if you are low income, maybe you're not going to the doctor very much anyway. You went and the doctor said, we're not going to treat you. So you think that you're not able to get treatment. And then now we have to go back and disseminate the word, hey, if you've got hepatitis, you're on Medicaid, get cured, get that curable care. And so we're in the process of a big public health campaign now just to push that out broadly into communities, because we had a lot of people in that boat. So that's the way, that's a big part of the reason working with FSSA and DOC on ending this. Because our Medicaid partners and our Department of Correction partners are specifically for hepatitis key players in bringing that to an end. So,
the total number that have repeated coming in and receiving packets, how are we through this program? Are they automatically being tested?
So they're provided with the option to test for HIV and hepatitis C at every visit. However, most of the time, once folks have started to test routinely, they kind of have an idea of when they're due for their next test. We encourage people who are at increased risk to be tested about every 3 months, and we have folks that will do that. One challenge that we have in some harm reduction certain service data in the state is that for very good reasons, the anonymity of participants is protected. So I might have an idea that, a middle-aged white woman is coming in and receiving services like myself, or it could vary, but that's all you're going to know. You're not going to know that it was Erica that came in for services. And so we don't have, the data that we have around testing is a little bit more anecdotal. We do have, of course, as Jeremy shared, we have referral data, so we know that we will refer people, and that your program has in fact referred people on multiple occasions for testing, and they're receiving testing services when they come in for services. But it's pretty much clockwork for them. Every 3 months they're either requesting that service if it hasn't, or taking advantage of that offer when it's provided to them.
But it's not required
It's not
to continue to receive the services.
correct.
Yeah, when we fund things, our funding is, the client has to consent. And so it has to be something where the person has initiated it. But this testing now is not where they have to sit down and have a formal, blood draw that has to go to the lab. We have 1 minute HIV test and we have a 20-minute hepatitis test. And so these things are done just very quickly, very low cost. The hepatitis test costs $18. The HIV test is $11 and some change. So I mean, this is really low cost. If you think about $30 every 3 months to screen folks who are actively injecting substances for HIV and hepatitis. One of the other big things too that we know is that in HIV's realm. Now we're working on what they call the continuum of care, and it kind of, I wish I had brought the graphic for everybody, but it talks about HIV. We have a well-developed continuum of care where 87% of people in Indiana that have HIV know they have it. So we know that there's about 13,000 people with HIV, and that represents 87% of the HIV positive population in the state. So we know about how many new people we're looking for. We're working now with Regent Street in Indianapolis, and they're taking all the hospital data, all the DOC data, from all kinds of different places, and they're developing the same kind of continuum for hepatitis for us, so we can estimate exactly how many people we're looking for. But with HIV, of the new transmissions that happen, 90% of new transmissions happen among the 13% of people that don't know that they have the virus. And so that means that when we have these robust testing programs out there, the more that we identify people, as soon as somebody finds out they're infected, it is highly unlikely that they are going to be the ones who are transmitting the virus to other people. So as many touch points as we have with high-risk folks to get them consistently in testing, the more likely we are that we're not going to have those same folks transmit the virus to somebody else.
Okay, so through the ARMS program, is the funding there for the testing, or do these folks have to come up with their own?
No. So all of the testing is supported by ISDH. So we part of the package of services that we help support counties with is the ability to purchase for free. Essentially, we have a website process where whomever is going to be providing that service can order as many HIV or hepatitis tests as they need to be able to service participants in the program. So no, it's no cost to the county, it's no cost to the participant. We want to keep services as accessible and low barrier as humanly possible. So that's something that we're able to provide.
Okay. So from the public health side of it versus the public safety side, how do we assure that the program is preventing the hepatitis and the HIV spread and not giving a hand up to someone that just wants to continue having free needles for their drug, their addiction?
Sure. There's been almost 40 years of research globally within the United States and within the United States that demonstrates that certain service programs don't increase anybody starting to use syringes. The only thing it does is it allows people who are already injecting to have access to safer supplies and reduce the risk of transmission from one person to another. So we have that data, the World Health Organization, the as Jeremy shared, CDC, as well as ISDH. We've looked at that research, and all of us as public health professionals support what the data tells us, and that is that these programs do not start anyone, it doesn't encourage anyone to start using. In fact, there was a study that came out late last week from the CDC that said that people that are part of syringe service programs are 3 times more likely to stop using substances because they have that access to resources and they have that support. Syringe service programs, there's the very scientific stuff that we're all kind of talking about right now, but there's also the very human part about it. And a lot of times in these situations, folks may not have that human-to-human connection. And so syringe service programs offer an opportunity for individuals to connect with another person and to have their value as a person and as a human reinforced. And so it can be a really powerful tool to encourage somebody to, maybe start down that path of recovery or say, I felt really good about myself after leaving SSP. I'm not gonna go inject today, or I'm gonna use less today because somebody cares about me and wants to make sure that I show up next week. So that's one of the things that I love so much about this as a public health intervention is not only do we have this almost 40 years of science, but we have that human part that, we can't always put numbers to.
And I tell you, one of the things prior to, and I'm sure you have varying levels of how long y'all have been involved with government programming, and I love the work that we do, but over 15 years, we've learned a lot about HIV, and so they, at some point in time, they would say, this is the new solution, and we're going to do this now, and this is going to fix everything, and then a couple years later, well, there's a new solution, and we're going to do this now, and this is going to fix everything. Well, for syringe service programs, the science has not changed about that, just the ability to have them has. And you look at the CDC and have Dr. Redfield here, and yeah, they're talking about ending HIV and hepatitis epidemics, but we're in a nationwide opioid epidemic that the CDC is funding, that they're really putting a lot of services in. Both FSSA, CDC, SAMHSA, pretty much every federal arm that there is, has been working on addressing this opioid crisis that we're in. And I think it speaks to the effectiveness of the programs to have Dr. Redfield reiterate multiple times during the meeting, because I was looking for, frankly, I think that I love our SSP opportunities. I was looking for, tell me how we're going to care for people, because I want to provide stellar quality care. As particularly, it was a HIV focus of that meeting, but tell me some best practices that you see nationally that we can do to move the needle on viral suppression. And, we want to get the states where all of our clients are over 90% virally suppressed. I had our epidemiologists run the numbers today. We're at 64%. Well, 2018, we averaged 60%. So to be at 64%, that's a big statistical change so far. So we're moving in the right direction, but we got a long way to go. And multiple times during that meeting, Dr. Redfield pointed to syringe service programs as being vital. And so I think that speaks to the efficacy of them. But on the same hand, I talk about making sure that the operation is right. And I think that that's why we want to make sure that our program is providing the support to have opportunities for consultation with professionals like Captain Hunter, who are very experienced with the operation of these and how to blend our work with the public safety side, because the programs are not going to succeed if that collaboration is not well thought out and strong. And so, there is work there that can be done to make sure that that's as smooth as possible. But I do feel like before we had the opportunity to have syringe service programs, we used to do these very expensive public health interventions. They were hard to do. They called them, it was called DEBI, the Diffusion of Evidence-Based Interventions. And, we used to go out and there was a program called Safety Counts. And they said, if people participate and they come to all the sessions and they do everything right, then they had a 9% reduction in their chance of getting infected. And, you know, that's a whole lot of money to spend for a 9% reduction. They weren't very successful, but that was the only thing that we could do. And then now, you know, we see a lot more participation and a lot more success with operating programs like these, and we see people who are actually engaging in treatment. And so I think that that's something, you know, that we can really point to. And now one of the good things too, we're about to roll out a new database that's going to improve our ability to work with people in the field. The initial database it's not a good one. It's not very user-friendly. We get the information we need, but it's hard on the state, it's hard on the people entering it. And I mean, referring back to the government side again, you know, I haven't been with the state for too long, but it surprises me that making the database was not the longest part, but deciding who gets the contract to do the hosting of the database has been longer than actual making the database itself. But now that we got that lined out, you know, you can do it on your mobile device, you can do it on a tablet. It'll be, you know, obviously for your computer, but then when people are out in the field, they have the functionality to capture that information as soon as you are meeting with the client. And so the input is easier, the output, the report functionality, the whole nine is really going to take it up to the next level for us to be able to track how these programs are operating and what benefits they're providing.
Well, I guess myself, my biggest concern about continuing the program is not having a structure in place to provide the service. We recently was with Fayette Regional, and they were operating it on a weekly basis, and I felt that we had great structure. I felt that we had great counseling and trying to move those folks into the next step of recovery. So as we've seen the dissolve of Fayette Regional and with our new efforts with Reed Health, we're just not sure where we're at with them and what role that they're going to play or not play. And so we're kind of hesitant on continuing a program that may or may not be managed correctly. And I think that's what's brought up all this discussion. I guess I've asked the sheriff here. He's been very much involved in our substance abuse recovery work and so on and so forth, other than just throw them in jail. I mean, I want to add that, and I think I'm safe to add that on Joey, that you're very much in favor of the programs out here that don't necessarily throw people in jail. And I kind of wanted Joey to kind of give us some insight of where are we 3 years into this. Now that we're 3 or 4 years into the program, I'm not sure how many years total we've done the harms reduction, but from public safety side of it, I mean, are the changes that we've made over time, have they improved the program from a public safety standpoint? Are we?
Well, I'll preface what you said before these 4 ladies here, myself and a few others are on the Drug Coalition. So, and I'm the current president of that. So I don't come in here with the typical law enforcement negative view on things like this. Now, when this was initially presented to us, the president of the commissioners was Frank Jackson, who was the sheriff that hired me, who then was elected as commissioner. And I worked 6 years working drugs. To me, I looked at it at that time as, we're waving the white flag, we give up, do what you want, we'll even give it to you. And was quite upset about it. And Frank being a mentor and someone that I still look to for advice quite often, he was able to say, listen, take the cop part out, put that over here, take the other side, the health part. And I think I have made some peace with it. I don't know, in talking with officers leading up to this, after Gary talked, I don't know, and I don't speak for both the sheriff's department and the police department, but I don't know that there has been a huge change in law enforcement's view on the program. We do see it as counterproductive in some ways. I know the health crisis we have to separate from the actual opiate addiction issue. But I don't know that that's changed a lot. And when I hear those numbers, and 95% sounds fantastic that we're getting those back, but there was 2,000 unaccounted needles that were just mentioned in that. When I pulled needles myself out of dugouts at the Babe Ruth field, when I've had kids getting ready to sit down, when we continue to get calls, not that this program, those 2,000 needles are those needles. I mean, probably a good chance they're not. But from our side, and what our job, just in the law enforcement realm, is to do, I don't know that we're ever going to be 100% on board. And that's, now, like I said, the treatment side of it, being on the Drug Coalition, we have a basketball program that we donate to local drug programs. That side of me, I understand it, and I do get why we're doing what we're doing here, and I'm not trying to entice an argument or anything like that. Just giving an honest opinion from officers. I have not seen a huge change in, they still are encountering people with that. They are getting lied to on the street. There are people trying to claim that they are going and they're not, and there seems to be some confusion. So as of what you spoke about, maybe some more education and more training would probably be, to me, the best thing if we are going to continue the program. Because I can speak for both departments. We have some great officers with both departments that are open-minded, and we do realize, things have just changed. I'm managing a jail where, when I first came in and worked as a jail cert almost 20 years ago, it was different when you brought an inmate in. They came in, they set the drunk tank, and you was able to, put them back in the block. Now we have jail clearance issues, which create some hostility with other departments, where we are routinely sending people to the hospital to be cleared for incarceration, because I don't want a lawsuit laid at all of our feet because they're coming in addicted to meth or heroin, and we're seeing crazy issues coming in that we've never dealt with. So we've had to change our mindset with that as well, and educating officers who just want to be mad that I arrested the guy, I don't want to bring him to jail, why won't you take him? Well, because if he comes in here and dies, or she dies, then I'm responsible for the county and protecting the county and keeping us out of litigious situations. So more education would be a good thing. I don't know that we're ever going to, like I said, it's probably going to be hard to everybody to go, yes, let's give them needles. And I was shocked in that initial meeting when I said, so they're just getting a needle, right? Oh no, they get the tie out, they get this, and I'm going, well, just let them, and my initial reaction was, just let them do the heroin. Just let them come right in there, shoot the heroin up, watch them, make sure they don't overdose, and then cut them loose. If we're going to take that huge a step. Now, that was my initial reaction as you go. I understand, and I do. 95% is a good number. But I cannot help but thinking, I heard 2,000 needles that are in this community. I have a 10-year-old and 8-year-old, and my daughter works for EMS here. Yeah. So she's encountering those. My guys are encountering those as they go to pat people down, that it's not something that was, I'm using this for diabetes or whatever the usual excuses we get. This is something I'm providing that could be infecting my daughter. My son picks those up at the ball field or on the playground. I can't help but having that reaction to it as the sheriff, and my reaction is to try to protect our citizens. Those are still concerning. 2,000 eagles is a lot to me. But in the grand scheme of things, 95% is a great number too. But
Well, I appreciate that, and I tell you, this is not something that is easy for a lot of folks. A person who was in a similar role to mine, different state health departments have different structures around if STDs are included in your division or whatever. We get all the fun ones in our division: gonorrhea, chlamydia, syphilis, hepatitis, all the whole 9 yards. But another division director from another state was at a harm reduction conference, and it's funny you say, if we're going to do all this, maybe we should just let them inject here and make sure they don't OD before we send them out. Well, some states do that. And so there was a harm reduction conference where they had a safe injection room. And it was at a state that didn't allow that, but they still had a safe injection room. And the division director from another state was threatening to call the local law enforcement and let them know that they were operating a safe injection room and that was against the law because they wanted that shut down. And so, there is, I can point to a lot of different things. And I have to say that, when I first started, I was 21 years old, and I was born and raised in Evansville. And it was interesting for me because we were still doing the safer injection kits back then. And so that's essentially everything that they give out, but not the syringe. And so, we've been doing that for as long as we have been able to. And, learning how to educate people how to shoot up safely. They did DARE in my school. That was something that was different. And I went to, I was going to be a teacher. I wasn't going to be a substance abuse counselor, but if you're going to work in this field and if you're doing public health education, that's part of what comes along with it. And so, I had to learn how to have a conversation with folks, just to approach them in a way where they felt like they could share that they were using substances, because a lot of times, like you say, people are even hesitant. Even if you're not law enforcement, you can be a healthcare provider and they still don't want to share that they're actively using substances with you, and just because of stigma and judgment and everything else. But then you build that relationship up, and they get used to working with you, and then you're actually trying to teach them how to save their life. And so I think that it's a tough place to be in. And I know that it's tough because when you are working for your communities, because we're all working for our communities, I'm working for your people here just like you all are, and you got to balance their concerns because it is true. But I tell you, I don't think that, one of the things that we also have to think about is we have a few hundred folks that are relying on the program. And so if we talk about, any alterations to that, we have to think about what the impact is going to be, taking people that, have access to stay healthier, and what does that transition look like away from that. And so I think that when we as the state, just want to make sure that we're being the best partners that we can, and we're going to support anything that y'all decide to do. And if we need Captain Hunter to come down, if we need to look at mobilizing other kinds of responses to help facilitate cleanup days or public information campaigns about whatever we need to do, we'll be there to support. And that is what our role is. And so we can't stress enough the public health benefits of continued operation. But we can help look for any alterations that we can find to make things work better, and to provide as much training as we can to make sure that you're getting the most out of what your community needs.
Now, I guess I have a question, if that's okay. Just for the public and to gain any public support for something like this, because I don't hear a lot of it in the public, to be honest, the people that I interact with is, the people that are on this program what's the longest person that's been on the program? Is there any of that data? Is somebody that's been successful to get off the program, and we're seeing, a good recovery story, which I love more than anybody. I love a comeback story more than anybody. But being able to, because to me, my mind goes to the methadone clinics, and when I worked drugs, we were purchasing through confidential informants this guy's weekly dosage, and he had been on methadone for 5 years, and there was nothing. I mean, he was just selling it, and there was no end in sight to that until he got arrested. That if these people have been coming to this program for 3 or 4 years, I'm just asking this as the public, I would think, would ask, at what point do we have to say, well, should be something moving in the positive here, that we're moving past this, then that, we're offering you all these services. And I know how that works. Like I said, I've been around for almost 20 years here. I've seen guys I've been arrested for 19 years just now getting it and going, oh, yeah, I don't want to do this anymore. I want my family back and all that. So and as a question from the public is, what's our longest person on and things of that nature. That may help them.
Sure. I don't have that data right in front of me, but we do, and part of it again is because of the way the data is tracked within the system. I don't know. I'd have to do some real interesting data pulls to try and get that out of our current system. As Jeremy shared, it's a very interesting system that we are vastly improving very soon. So I would have to look. Yeah, I'd have to look into. Yes.
It's the best thing that the cheapest option could provide.
Yes. So I can, that's certainly something that we can look into. I will say though, and that was one of the reasons that we do have those quarterly reports that counties submit to us, and we encourage on those county reports or on those quarterly reports that are provided to us successes and challenges certainly, and part of that is so that as those successes come up, we can share, we can celebrate those. And as those challenges come up, we can also look into what can we do as the state health department, if anything, to help support that and to kind of shore things up a little bit. So that's kind of an ongoing process. And then in addition to, further provide some quality assurance around that, we also do at least annual site visits. So myself and my colleague will come to the sites and spend a day kind of looking at operations. Again, is there something that we can do to help kind of improve things? Are folks getting the services that they need? We hear this quite often, and I would have to, do a little bit to find out any specifics about this particular county, but it is not uncommon for us to hear that somebody has quote unquote, brought in their syringes for return, and they're like, you know what, I'm done, or I'm getting into recovery and I want these to be disposed of properly. One of the things that we really coach programs on, and Fayette County is no different, is that is proper disposal, and that is one of the it's kind of a rights and responsibilities, right? Like this is a program, and we've got these things that we're offering to you, but you have a job and a role in this as well, and part of that is properly disposing of your sharps. We give you the materials to do that free of charge, and you can bring these back to us anytime. And I think that's one of your return rate really speaks to the fact that that's something that in your community people take really seriously. That's ownership in their community. And so, what can we do to improve that? I'm not quite sure at this point because you guys have such great numbers, but we'll certainly look into it. We want, as Jeremy said, we're all working for that same goal of healthier communities. So if there's anything at all that, maybe we need to spend a little bit more time, maybe trying to figure out if there's some stuff we can be doing better, we can support better. One option that a lot of communities are taking advantage of is putting like sharps container or sharps disposal places or containers or whatever in more public places or in businesses that are willing to have them, so that they can properly dispose of those sharps. Anyone can. It's not only great for people who are using illicit substances, but if you've got somebody who's diabetic or is taking other medications, somebody's trying to check their blood sugar, their Lancets can go in there. So there's lots of things that we can do and we can kind of talk about to better personalized services for your community. That's something that we do across the state anyway. And as you guys are kind of transitioning with your program a little bit from the hospital or from Fayette Regional to whomever that qualified entity is going to be here, that's what our job is to support those operations, to be there, and figure out what we can do best to support your community, because it's your community and we want that.
I was at a place not too long ago where I wanted to say it was the government center, but I could be wrong, but there was a trash can that said no sharps on the trash can. And I was with a colleague of mine, and we were attending a meeting, and I looked around the bathroom, and there was no sharps container in the bathroom. And I said, well, it says no sharps on the trash can. You'd think that there would be a place for sharps, in the bathroom just for folks who might need it otherwise. And so, I think that one of the things that is for sure is that we are not going to syringe service program out of the opioid epidemic. But it's a tool that we have. And it's an amazing tool that we have that can keep people healthier. Can reduce the number of emergency room visits. It increases access to Narcan. It does save lives in that regard for sure. But we do have bigger issues that we're going to have to come up with creative solutions to talk about, because as we look at ending hepatitis C and HIV, the opioid epidemic is going to play a big part in that. And it's not our goal to have people continue the risk behaviors that put them at such a high risk for these infections. And so there will be an increased access, and we already have done that for our folks with HIV because we have a payer for it, by extending substance use treatment services and mental health services. But obviously we know that our state in general, access to that's a problem, and then when we lose great programs, like we did recently here, that continues to limit access. And so that's something that is an important part on our radar, and it's a big priority for FSSA too, because we need to make sure that when people make that decision, that they have a choice of the kind of programs for treatment that are going to help them be successful. And like I mentioned earlier, it can take several attempts at sobriety before people actually can succeed. And so that's another big piece of what it's going to take to bring this to a close, because I think that we're seeing some positive movement. I think that we are seeing improvement in the opioid epidemic, but as we all know in this room, this is something that is really, really a big challenge for people to walk away from. And it's not one size fits all as far as the programming goes. So a long way to go on that front.
I would like to say something. From working in the exchange, I would like to say that successes are measured differently for everyone. In my first month of working there, I got to send someone to treatment. In a week of him being out of treatment, he died. But the success of being able to connect him to a service was there. And I have seen people that now are incarcerated that have been participants in the exchange program. So to me, they're still alive, and that's been a success, because handing out doses of Narcan has helped people administer that to someone else, and that person is still alive. I've seen people get their children back. There's currently someone that's working at Walmart that was a long-time exchange participant, and every time I see this guy, I don't go up to him and say, like, hey, how are you doing? But I smile and go on, because now he no longer wants to be acknowledged, and you can tell. I've had the opportunity to give people resources to go to Breonna's Hope, and as we've seen that program into a little over 2 years, there's now anywhere from 50 to 70 people through those peer support services that are going. So for you, success may be someone that's totally clean and now in church on Sunday. For me, success looks like that they're functioning and they're not spreading that Hep C or HIV to their children, or to my child that's still a school-age child. So to minimize that risk in the public is really the goal. I can go buy syringes at Walmart in Richmond saying I'm a diabetic, so I can get them through the exchange, but I can also get them anywhere that I want to get them. To know that we have that opportunity to make that connection and offer those services is a big deal. It's huge, it's huge.
Erica, our phone conversation the other day, if you can refresh my memory on our options, you said that the 13th, we need to make a decision prior to the 13th whether to extend the program for a year or up to 2 years. However, we can, as a board of commissioners, we can suspend the actions of the program. We can vote to continue it, but we can suspend the actions until we deem a program that is sufficient in our community. Correct?
Yeah, so just to kind of outline the options for folks who may not be familiar, at this stage, there's a couple different options. Option one is that the program is approved at the local level. So that happens through the commissioners. And then from that point, the commissioners can either go ahead and move, you guys can move forward with a qualified entity, or the health department can provide services. Or option two is you guys as a community can then send that to the state health commissioner for her approval. So that's the way the law works. Most places thus far have been utilizing that local option and you can elect again, as you shared, either for a period of 1 year or a period of 2 years. And then from there, again, the decision is whether the local health department does, provide certain services, or a qualified entity provides those services. Previously here, a qualified entity had been doing it. That was the hospital. They are not currently operational, so there are not certain services locally at this time. And so, if you were to approve it for that period of 1 or 2 years, which again, that's a decision that you guys as commissioners in the community make, you would then need to decide who that qualified entity is, whether it's another organization within the community that comes forward and says that they want to provide those services, if it's, someplace that's maybe already, has done it previously, like some communities just kind of have a qualified entity that's always kind of doing it. But really it's the decision, it's a local decision, meaning that, we don't tell you, we as the state health department don't say this is the person you need to use or this is the group you need to use. However, once that qualified entity is selected, let's say, if you do approve it on, when you have your vote, we're always going to be there to provide support. We're always going to be there to provide technical assistance to whomever provides those services. That is why I'm here, is to be able to provide that hands-on, one-on-one support to whomever, is going to be providing that service. So that's kind of the breakdown of things. So at this point, you guys will need to make a decision how that renewal made. If you decide to renew, doing it prior to August 13th, and if you elect not to renew or let it go, then still would need to notify us at the state health department per the state law. So it's just determining if you want to continue with the program or not, and if you do continue with the program, who's going to be delivering services. Once it's determined who's delivering those services, that's where, we as the state health department will jump in and wrap our arms around that, whoever that entity is, and get them up to speed. If it's somebody that's not already providing services, and make sure that they're complying with best practices and all those other sorts of things. That's what we're here for. And we can be as, hands-on as we need to be in those early days, or, depending on, if the entity has already provided those services previously, we can be a little bit more hands-off. That's why we always say we're here to support whatever's best for you guys locally. That's what we're here to do.
We can also review, if we are looking at new entities that might be coming on board, these programs work differently in different communities. And so when we talk about how the syringes are exchanged, what the exchange rate is, the frequency of the operation, all of those kinds of things, we can take a look at and review the options so that we make sure that you all have confidence in that they are operating what works best. So they can try to mitigate some of the concerns that you have and incorporate some of the ways other programs operate. And I think that y'all were early adopters, and that's fantastic because your hepatitis rates warrant it. But I think that now we have data and we have other places in similar communities that we can look at and see how their programs operate to see if there's something that kind of sparks your interest about maybe could be an improvement on what has traditionally been done here. And I think that that's, one of the things in our statewide planning for ending the epidemics, that dissemination of best practices is very important because we don't want there to be disparity in how people are achieving health outcomes. So we want to make sure that everybody is rising together as we do this. And so there will be a lot of emphasis on that as we continue to move forward. And, it's not the most exciting thing, but, the new database is going to give us a lot more flexibility with how we're able to access the information to track those trends and to replicate success across the state.
One thing that I might add that the sheriff was talking about some of the stats of how many people have obtained services or treatments and so on and so forth. But I haven't, just the recent quarterly report, and you were saying, well, that data is kind of hard to get. Well, what I'm reading here, you're not going to be able to get that data because you're not even asking those questions.
Well, so we also, we have the database has, it has questions we find out how many folks are getting referrals to services. And one of the other questions that we do ask is how many folks are engaged in recovery services. And it can be, that's something that is anecdotal because, again, we don't have personally identifiable information. So I don't know, for example, that Jeremy has entered recovery services, but I know that a gentleman around his age has entered, is saying that he is entered into services. And we have a lot of that also on the back end as well. So we know how many folks are getting referred. We know when the new database takes into effect, we'll also have, some slightly more specific data about like if they did enter into where it is that they said that they were going for recovery services, for example. Right now it's a little bit more lumped together, and that we ask, are you in what kind of recovery services are you receiving? And they can fall into some categories, but we'll have a lot better idea with this new system of, they went to a 12-step program and they're also involved in an inpatient residential program. So we'll have a little bit more, but again, it's all self-reported. It's self-reported and it's anonymous because we want to protect people's confidentiality. And so that when they do get into, when they are in recovery, if it's not something that they want to talk about, their anonymity is protected. So we're always kind of balancing that fine line between those. And we do have, again, some data as, I shared with Jeremy and he shared with you. But our quarterly reports will be modified, obviously, to reflect the changes in the database. That's something too.
One of the things that we're trying to do is we're trying to collect, and I don't want to violate anybody's privacy, but from my perspective, it's very difficult to sit at 2 North Meridian in downtown Indianapolis and plan these health strategies without the data. We've got to use this. We have got to make sure that data informs the decisions that we make. And so with the new database, we really work with our legal department because the law is very specific about what we can and can't do as far as the state law that allows us to operate the exchange. And so we want to collect as much information as we can because we can't make good decisions without it. And so we really have flexed out our muscles to the greatest extent with this new database to make sure that we have every tool that we can use, because we want to make sure, as we talk about implementing best practices, that if there are places with better options for recovery, counseling centers, whatever, and that we're noticing that people here aren't accessing because y'all don't have that kind of service here, that we're investing in those services here because we know that we have people that could benefit from it. I mean, I think that, really making sure that we are approaching it from every angle, because I mean, when we talk about people with HIV, for instance, when we talk about them having a suppressed viral load, they could go off their medicine for 3 months and lose their viral suppression and be infectious again. And so, if maintaining, if they are, or if they get a severe infection because they're reusing needles and they are getting infected at their injection sites, that can affect their viral suppression. And then we have some of the most high-risk people out there doing the things that we're trying to prevent. And so, I think it's just really making sure that we're capturing as much as we possibly can, because that's a priority for us. And not in a punitive way, but just in a structuring public health strategy way.
Well, on the part where you said we could delay the program and still keep it until we found somebody that wanted to take it up. Okay, if we delay it and we find somebody, what do we have to do? Have our health department approve the people that's going to take it up or what?
So just to kind of clarify that a little bit. So so if you elected not to renew it, you would have to start from scratch by the health officer declaring a public emergency and then putting together a plan and bringing it to the county commissioners. So that's kind of what the process would look like. Whereas if it's renewed for, whatever period you decide upon, when that organization or entity steps forward or you make that connection or however that happens, they can go ahead and begin operations once everybody feels comfortable with it. So again, that would be, where we can step in and provide that support and getting them up to par, as it were, for lack of a better word, to be able to provide those services. Unless they've already been doing it before and they know exactly what they're doing, and it's just, a matter of us, again, kind of supporting and making sure that you're comfortable and they're comfortable. But the process looks different depending on who that qualified entity is and how we can support that.
Every year, Dr. White will have to
Every 1 or 2 years.
Every 1 or 2 years. So that's part of that renewal process.
I don't know what the definition of an opiate emergency is, other than my intuition tells me we still have one.
So you're the local health officer. So
By reading the paper, I see people dying all the time. I see people in my office with Hep C and not being treated. But I think that's my job, is just to get the word out that there's an emergency. Then I've always relied on my staff to do the logistics.
That's one of the things, the renewal part is procedure.
Yeah.
Right? And so the operational piece is where you all select the entity that can do that. And so I think that's the renewal is, as long as you renew before the expiration, you all could not have an operational program for the entire period of time that you have renewed it, but the renewal gives you the option to decide when the qualified entity is ready.
Except once you get the thing up and running, there's a personnel that's then what it costs, right?
So again,
I would just because we also have some people here that may help with that personnel cost piece of it.
There you go.
And they also have experience running it that came from Bloomington. And so I don't know who the best person to speak is, but it's that side of it.
Sure. Sure, I can start. My name is Allison Green, and I'm here from the School of Public Health at Indiana University. And the reason that we're here is we're partnered through a federal grant that we received that's a 1-year grant specific for Fayette County. It's a rural community opioid response planning grant. And we have $10,000 within that grant that's specifically allocated for syringe exchange services. We had originally proposed a subcontract with Fayette Regional. And so we've now been in conversation, we're working with Holly and with Kay and Sarah, and figuring out kind of about that $10,000. So that $10,000 can be used to actually help with this transition and with startup. However, this group would see kind of fit, however, kind of whatever the commissioners would support in terms of moving forward with that $10,000 to pay for things like staff time or training for a robust volunteer program or whatever it would cost to really kind of build a program with integrity based on kind of evidence and what we know around the country to be best practices. So in addition to what we're hearing from the state as support, there would also be support both in terms of dollars from this grant as well as expertise and some opportunities for training where we could come and provide trainings and other kind of resources like that. While this is just the 1 year for the $10,000, this is just a year of a planning grant. We anticipate we're applying for and anticipate hopefully having a future multi-year funded implementation project, which would provide more funding for this type of harm reduction programming that then again could be used to kind of further support. So I think that's kind of the basic of those. Those funds can really kind of be used to help develop policy, develop procedures, kind of put things in place in a way that the community feels like is necessary to move forward in a positive way.
And so that's obviously in addition to we have guidance documents, we have, on-site technical assistance. I mean, it sounds like there's a couple different, resources.
So I'm also part of this crew over here. Sorry, there was no seats at the table, so we were in the back. But I'm also with the School of Public Health, and I'm Carrie Lawrence, and I serve as the Associate Director for the Rural Center for AIDS STD Prevention, and I've been really on the ground floor with some of the grassroots efforts, and I can tell you, being involved with our local syringe access program in Monroe County, that it's very community driven. So we're housed with the Indiana Recovery Alliance, so it's an independent nonprofit that, where we were 5 or 6 years ago, where we are today, I have seen some significant transformation, including we run 2 NA groups that meet on Friday and Saturdays at the syringe access program location, on top of all of the stuff that was explained by the State Health Department as far as services. I would say the majority of the services we provide that have been the most effective are linkages to care, testing, prevention, treatment. We offer clothes, toiletries, I mean, so many things beyond just the syringe services that people who are not injection drug users and seeking safe works, they're getting a lot of other resources that vulnerable community members need. And we work with multiple faith, like all of our churches, our homeless day center, mental health. So we have developed this network of really, it's the community that's driving this broader harm reduction effort, and not just syringe exchange, and not just in a public health framing. We work with, in fact, I was working with our law enforcement, who we just implemented a law enforcement assisted diversion program and found grant money to fund a social worker who actually goes out on patrol. And so working with some of those vulnerable folks and getting them hooked into services that are needed. So it's kind of like, it's more than just the syringe and the public health angle. Actually, this is really this whole community approach, and everybody is doing what they can to curb the harms associated with not just our opiate epidemic, because we've had situations after spending 16 years working in child welfare and juvenile justice. Methamphetamine was being fueled, and we've seen a resurgence in that, and up in northern Indiana with some of the research and work that I do up in those communities, crack cocaine is still a major issue. So really kind of tailoring the needs of what your community needs with what community, leveraging a lot of the resources that are here locally.
I felt like I had several conversations with Dale just about these folks because it really connects even with what you were saying at the last meeting about wanting to have wraparound services for people where they can come and do what these people offer, but also potentially have access to greater support. And so I felt it was really important for you to hear that those resources are available and there's even some money there to help support whomever wants it.
Mark, do you have any further questions? Dr. White, as health officer, do you have any questions for Erica?
I think when they stole my thunder, I think they told us everything I've kind of been aware of. My only question is who's going to run it, where we're going to have it. I know Paula did an unbelievable job. She's kind of on, I think she's with behavioral health now and will not be involved in the renewable exchange program. She'd like to be, I think, but I think she's moved to a different role. And she was sort of the SEP superstar.
And I have another little tidbit, because I asked Dale, like if I could have a conversation and ask. Again, we have said we would be glad to do whatever. But there have been another person at the table that has said they would be willing to offer housing of it, not the running of it. And that would be amazing. And Jessica is the director at Meridian and she's at the table.
Well, can I say something?
Yeah, sure.
I'm Craig Kenyon, CEO of Reed Health. And for those that don't know me, I've been at Reed for 24 years. I've been here at Fayette for 5 years before that. And I was on the Fayette County Drug Coalition back when Bob Waddell.
It's a long time ago.
Yeah, I think even sure.
It's a long time ago.
So I've been on the ground floor of that here. I've been very supportive of the program in Wayne County on the ground floor of that startup. It's amazing to me there's just 9 counties that are doing this out of 92 in the state. I think you get, real kudos for doing this because you are addressing an issue. We see this issue in so many ways, but this is one way of trying to intervene. We intervene in a lot of ways, and our program is structured perhaps a lot different in Wayne County than it is in Fayette County. Reed is 100% supportive of that program in Wayne County. We're 100% supportive of the program here. We could not purchase the building that it was currently housed in. The bank would not let us buy it. They think they could better their deal by parsing off of things that are not involved in the clinical programs we're running, like Whitewater Valley Care Pavilion, physician offices, and the main campus. Anything else that wasn't connected to that, they didn't want to sell to us. So we've made attempts to see if the property is for sale and can they return phone calls. So we don't know where the bank is sitting with that property. But we do supply significant support. We do provide the reception staff with Centerstone. They're moving to take over that in Wayne County completely. We provide health insurance navigation service. A lot of these folks don't have insurance. We provide the funding for the syringe exchange supplies, of which there's significant listings of those. We take care of the sharp biohazard waste removal. We provide education, and we provide office supplies and education materials. So Centerstone has other roles. It really doesn't matter to us. Centerstone, Meridian, whoever wants to do it, we don't care. So we just want to see the program continue and thrive because we do see this as a way of pulling people into other treatments. If we get them into chemical treatments over time, that has a success rate. There's no 100% silver bullet in this. It just doesn't work. We work with our population enrichment. We plan on working it with here who are pregnant moms to be, who are addicted, working to get them into chemical treatment during pregnancy and work with them post-delivery, providing long-term birth control for them. There's a lot of things that we do connected to this because it touches so many different areas of what we serve. So I just want to make that statement. If there's any ambiguity of where Reed stands on this, that's where we stand.
And if I could add, one of the reasons that Meridian has volunteered to be a host location
in my vision is, we have syringe services on one side of the building and behavioral health care on the other. If somebody's ready to make that commitment, ready to make a change, we're available, we're there. There's just all kinds of opportunities for treatment.
You're talking about 707
West 3rd Street, yes. So those opportunities, we also have a Medicaid enrollment specialist that would be, we would arrange her schedule to be there during those times. There's just opportunities now.
Well, I think I've made my stance very clear as far as the program. I'm not against the program as long as we have a structured program that gives them a direct avenue to more services. I don't want to stand on the street corner just giving syringe packages out. I want a purpose behind it, and accountability. I want these numbers every quarter that I'm getting now in emails that I wasn't getting earlier. But I want accountability, and I want a structured program to get them farther. I just don't want to give needles out. I want to give programs out. I want to give services out.
Get people off the drugs.
I want to get them off the drugs. I want to get them in treatment for hepatitis. So that's my concerns. And right now, I can't promise that, having that capability, because we lost that structure, and that's why the hesitation in our decisions. It would have been very easy to sign off if we still had Vet Regional in the program. But we have scheduled a meeting for Thursday to make this decision. I want to give Dale the opportunity to be present as well. So we will be in session Thursday at 3:30 in special session to make the decision whether to extend it or not. But most likely that will be contingent upon temporarily suspended until we can see a structured program.
And it sounds like, there's some options, some really good options that from what everybody just shared. And I absolutely, it sounds like, IU's willing to support, obviously the state health department's willing to support. So it sounds like there's a lot of really great people in the room that are, want to be as supportive as possible to make that happen. And that's, I think, anyone who's anyone who supports harm reduction, certainly our goal is to keep people as healthy as possible. If somebody's ready for recovery, we want to make that as easy as possible for them to access those resources. So.
Well, and I do want to just say too that I did not mention that the state has placed an additional $500,000 into our hepatitis program to do a statewide program to connect the highest vulnerable groups to substance use services to do that linkage to care model, a blended disease intervention linkage to care model actually. But I did have an opportunity to meet with the governor's team last week and request additional ending the epidemic resources. And there was a warm reception to our early plans for ending the epidemic. And so there will be increased resources as we move forward. I'm convinced both state and federal that will help further support that. So we are anticipating. They have said that they are going to be putting an additional $1 billion into the ending the epidemic push, and that will come through CDC, HRSA, and SAMHSA. And so we'll see a lot of additional money coming in to support those activities.
I'd like to take this opportunity to thank everybody for input. It's not as easy of a decision that everybody seems to think that it is on either side. I've talked to a lot of people that are totally on the other side, and they seem to think it's, you know, why waste your time? Why are you wasting your time? And there's people on the side that wants the program to continue that says, why are you even wasting your time? This is a no-brainer. You need to be continuing this. So I hope everyone understands that this is not as easy of a decision for this board to make as everybody thinks it is. But however, I guess that's why they pay us the big bucks. And we will make a decision on Thursday, prior to the 13th. So that we can, if we choose to continue the program, we can get that paperwork done.
Absolutely.
So-
And obviously, if there's anything else that you need from myself or Jeremy, and you've got our contact information, and, you know, please let us know.
All right, thank you very much.
Thank you.
Is there, Mark, is there a motion to adjourn?
I'll move to adjourn.
Second. All in favor?
Aye.